Good evening, everyone. Welcome to AVPN's first South Asia Impact Capital Festival. I'm Dendra Rikmas, Senior Product Associate with the Knowledge and Insights team at AVPN. I will be your MC for this session, and I'm delighted that you joined us today. For those of you who don't know about AVPN, we are a network of funders and resource providers with over 600 members across 32 markets. Our mission is to move more capital towards impact in Asia. By providing social investors like yourselves opportunities to connect with key stakeholders across various sectors and markets, to learn from one another, and to find opportunities for action. We are sharing highlights of our day live on Twitter, so don't forget to share your experience with us by using the hashtags #AVPN South Asia 2021 and #Social Impact. Throughout this month, the festival will spotlight best practices and solutions that AVPN members are delivering across India, Bangladesh, Nepal, and Sri Lanka. They will address issues ranging from healthcare, livelihoods, climate action, and education, all of which are particularly urgent in the sub-region today. Before moving to the program, a few housekeeping announcements. To download any session resources, please click on the download icon in the agenda page, which is next to the session title. To continue chatting with your speakers and fellow delegates in this session, please make full use of the messaging function or the event feed on the platform. Finally, please note that this session will be recorded and you will be able to access the recordings for 3 weeks after the festival. This week, the festival focuses on healthcare. And with that, we look forward to hosting AVPN's inaugural Grandstand session on an issue that currently moves society like few others. The Grandstand is a platform for us to showcase the most impactful ideas on the ground, straight from the source. Be captivated by the stories of project leaders who will take you on a journey into the beating heart of practical social impact. Each presenter will be given 7 minutes. As our first speaker, I'm pleased to invite Shama Karkal from the Catalyst Foundation. Shama will be sharing about their work to reach the unreached in health pandemic. Shama, please.
Thank you, Dendi. Hello, everyone, and thank you, AVPN, for this platform. I'm Shama Karkal, and I'm privileged to be here on behalf of the COVID Action Collab to share with you how we've been working on reaching the most vulnerable during the pandemic with a focus on health. Even prior to the pandemic, the normal wasn't working for vulnerable people, people with disabilities or migrants, who are often invisible, unheard, and difficult to reach directly. The multidimensional issues of health, livelihoods, education, and living standards, which affect nearly 1/3 of Indians, have been aggravated by the pandemic. And there is emerging evidence that the achievement of the SDGs could be delayed by a few decades without significant collective efforts. I'm going to share some voices from the ground, curated by the partners of the collab. These snippets were shot by people themselves a few months ago. Next slide, please. And this will be the video.
हमारे घरों में कमियां आ रही हैं
6 ವರ್ಷಕ್ಕೆ ಮುನ್ನ ನಾನು ಎಲ್ಲಿ ಕಷ್ಟಪಟ್ಟೇನೋ ಅಂದ மாதிரி நான் இப்ப ಕಷ್ಟಪಟ್ಟಿட்டு இருக்கேன்
ಆ ಟೈಮ್ ನಾವು ಏನು ಮಾಡಿದ್ವಿ ಅಂದ್ರೆ ಆ ಹೆಣ್ಮಕ್ಳಿಗೆ ಆರೋಗ್ಯ ಸ್ಥಿತಿನೂ ಕೆಟ್ಟಿತ್ತು
गांव में आना जाना बंद हो गया ट्रांसपोर्ट भी बंद हो गया था बस भी नहीं चल पा रही थी जिस समुदाय के साथ हम लोग काम कर रहे थे उन लोगों से बातचीत नहीं हो पा रही थी क्योंकि उनके पास फोन नहीं होता है
लॉकडाउन में हम लोग का काम बंद हो गया हम लोग सोचें जितना लगा तो क्या करें अब नहीं करें हम लोग कमाने खाने वाला आदमी है कैसे चलेगा घर परिवार हम लोग का
என்ஜிஓவோ மற்ற நிறுவனங்களோ அரசு நம்மளால் தனித்தனியாக இருந்து இதை வந்து ஒழிக்கணும்னா முடியவே முடியாது எல்லாரும் ஒற்றுமையாக ஒன்றிணைந்து செயல்பட்டால் கண்டிப்பாக வந்துட்டு நம்ம எல்லாம் இதுலேருந்து ஜெயிக்கலாம் இந்த கொரோனாவை முற்றிலும் ஒழிக்கலாம்
हमारी एकता ही हमारी शक्ति है हमारी एकता ही हमारी ताकत
We are strong together.
Clearly, even children agree that we are stronger together. The COVID, next slide, please. The COVID Action Collab strategy and focus on the vulnerable and their needs is visualized in this framework. The outcomes that we seek to achieve are resilient and thriving vulnerable communities, effective, efficient, and resilient institutions, and a dynamic humanitarian response ecosystem. We are using a three-pronged strategy. The first one is to capacitate, meeting the local and varied needs and priorities of vulnerable groups. The second strategy is to connect. Partners of the collab contribute their expertise and tools, as well as receive support through systematic exchange. Construct is the third strategy. Complex challenges raised by the pandemic have required systems thinking, innovation, and co-creation. We've brought impact-focused partners who can rally around one ultimate outcome, for example, better surveillance, to achieve scale, impact, and sustainability. Next, please. This people-centric, multidisciplinary collaborative is present in the next one, please. Thank you. It's present in all of India's 28 states and union territories, reaching 3 million vulnerable people with an ambitious plan to reach 10 million in the next 2 years. So far, the collab has supported the delivery of 1.7 million instances of services. We are 300 partners strong and growing, with about 13 million raised for communities as well as partners. Harsha, if you can move to the previous slide. Our world has changed beyond recognition, and to make a real sustainable impact, collaborative action is no longer optional. As a collab, we address the issues of suboptimal delivery models and organizational fragility. Funding can also be efficiently utilized at scale, but funding is critical and currently insufficient. I'm going to describe 3 health-specific interventions that the collab has worked on in the last 10 months. If you could now jump to, yes, thank you so much, Harsha. During the pandemic, most governments utilized mass individual testing to track the epidemic waves through COVID-19 positivity rates. My city of Bangalore in India arranged for over 35,000 COVID RT-PCR tests a week to calculate zone-wise positivity rates. This is very expensive. Despite Bangalore having done the most number of tests in the country, it has been insufficient from a rapid surveillance and a tracking of COVID cases and prediction of the next COVID wave. With COVID-19 vaccinations rolling out, along with priority groups, we need to determine the geographical clusters which are going to be most at risk. Countries around the world have been using wastewater surveillance for years to determine which diseases are spreading. The government of Karnataka has approached COVID Action Collab to set up and run the country's first public health surveillance unit for Bangalore's citywide COVID surveillance. Next slide. The need for frequent sanitization of the workplace and common facilities, including vehicles, and all points which come into human contact became a need during the pandemic. This has presented an opportunity to repurpose livelihoods in vehicle and building sanitization while addressing the pertinent challenge of COVID-19 transmission. The COVID Action Collab brought together partners and developed an entrepreneurial program. Unemployed women and youth receive online training in disinfection of different types of surfaces, as well as incubation support to start their own venture. Depending on the volume of work, an entrepreneur can earn over Indian rupees 7,000 per month. So far, there are over 300 sanitization and hygiene entrepreneurs in urban locations of Tamil Nadu, Maharashtra, Odisha, and the capital region, which form the nucleus for further expansion as well. Our aim is to support our partner LaborNet to expand to 5,000 sanitization and hygiene entrepreneurs by 2021 to provide quality disinfection services in their neighborhoods. Next slide, please. We all experience services moving virtual. Healthcare for non-COVID conditions was one such new experience for all of us. Telemedicine grew faster in the last 10 months than it probably did in the previous 10 years. Now, how could this work for the most vulnerable in rural, urban, and tribal locations? At the collab, we used our collective strengths to enable telecare, not just healthcare, but social protection, mental health, and COVID surveillance as well. Working with local organizations who had the community rapport, we brought clinicians and technology together to reach the unreached. Next slide, please. We've brought diverse organizations together to bridge the different silos that we often find ourselves in. If you join us, we are confident of supporting 10 million people to thrive through the pandemic and accelerate progress towards the SDGs. Do reach out to me and the COVID Action Collab so that we leave no one behind. Thank you very much.
Thank you so much, Shama. And it's always great to see the great work that you're doing and reaching out for partnerships as an end to the presentation. So up next, we have Deepak Sapkota and Dr. Annet van den Hoek from the Karuna Foundation, who will share more about scaling innovative, cost-effective healthcare through public-private partnerships in Nepal. Deepak, Annet, please.
Good evening, everyone. I'm Deepak Sapkota from Nepal, and I do have my colleague Annet together with us. Today, we'll be talking about scaling community-based disability care project in Nepal, which is a public and private partnership, an unique and entrepreneurial model that we have been working in this country. Next slide, please. So when we talk about people with disabilities and this program, people with disabilities are always neglected and left behind. So this program aims to reach 100,000 people with disabilities in the whole province of Nepal, province 1 of Nepal. For your information, there are 7 provinces in this country. We also aim to contribute on prevention of childhood disabilities by strengthening maternal and childcare services, with specific focus on managing birth defects and screening in the early stage. Next slide, please. The program is known as Disability Prevention and Rehabilitation Program, and it has 2 major components, and that is strengthening community and healthcare system. When we say strengthening community, we are developing a strong community system that can deal with the community-based rehabilitation project related to people with disabilities, and also improve maternal care to prevent disabilities and save lives. In relation to success, what made us to move further? The program has been developed together, as said, with government of Nepal, and then we do joint planning with government. The cost has been shared by all 3 parties, the province, the municipalities, and Karuna equally. We do have a strong collaboration and cooperation with technical partners like Medic Mobile, Eye Care Center, Hair Care Center, Autism Center, and many others. And through the community-based health workers, we provide door-to-door care to the people with disabilities, including therapy and some basic medical intervention. And we also do have very strong exit arrangement when we sign the agreement with the government of Nepal. Next, please. If we talk about achievements, what exactly has been achieved until now, the model has been developed, tested, and implemented in last 12 years in couple of pilot districts of Nepal. The province 1 of Nepal has adopted this approach in 2019. At this very moment of time, we have reached to 58 municipalities out of 113 and manage. So we are managing it, and the co-fund is there. We have appointed, the program has appointed 260 local healthcare workers, and they are also being trained on therapy and many other part of disabilities. We have reached 24,500 persons with disabilities so far, and 7,000 pregnant mothers. Next, please. So in terms of challenges in scaling, my colleague Annet will talk a little more about it, but before saying bye to you all, the COVID has created significant, impact in our work. Despite of all those odds, we have been able to reach to our target groups, and we're in very constant and close contact with all of them to provide very basic medical services and food supplies during the COVID. Thank you all. Annet, please continue.
Yeah. Thank you, Deepak. Yes, from the Netherlands, with the Karuna Foundation NL, we support the implementation and scaling of the program in Nepal. And what we've been doing is we organized a group of private funders who committed themselves at the start of the whole scaling, and they committed themselves to the funding of the first half of the province. So that means the implementation of the program in 58 municipalities. And with this committed funding, of course, we could start this public-private partnership. So then also the government of Nepal was able to allocate funds in total, even 9 million they committed to the scaling of the program in the whole province. And of course, there are quite some challenges. Deepak already meant the first challenge is that we had a serious delay in the start of the implementation of the program. And of course, we have to keep all these funding partners motivated. They want to see results. But I think, as you could see, we have a strong team in Nepal, and I think they're agile, and we aim at catching up with the work in the coming 6 months. It is a government program. So another challenge is that, of course, we have to keep political momentum. You know, right now, all officials and politicians are really motivated and committed. But we may have new elections, so it is a challenge to keep them connected and make sure that they keep allocating funds. And so far, I think the team is doing really well in establishing very good relationships with the government. We're also developing a plan for the start of phase 2. So that means the second part of the province in 59 municipalities. Of course, we will learn the lessons from phase 1 and see how we can scale the program and introduce it to the rest of the province. And of course, we do have a funding opportunity in starting phase 2. So that's also why we are looking for new partners. And we would like to invite you to see, okay, whether you want to and can join our journey in this introducing and changing the healthcare system in Nepal. I think so far, we are very positive and optimistic, and even recently we've been approached by other provinces who are also interested to start the program. So we look forward to the coming years. Thank you.
Yeah, it's done. Thank you.
Thank you so much, Deepak and Annet. Up next, we have Dr. Shagun Sabharwal from JPEL South Asia, who will share more about impacting local health activities through community ambassadors and social networks. Shagun, please.
Okay, thanks everyone. So these were some really rich presentations. So my topic is actually going to be focusing on some social networks theory that can play a very important role in helping us design interventions that can really improve preventive health. Next slide, please. So the basic premise of my presentation is that behavioral science and insights from behavioral science that try to understand how do we as individuals decide among choice, how do we think, rationalize, and act can have an important implication in the design and implementation of policies. And I think what's really important to note here is that especially a lot of the schemes, you know, and especially in the space of preventive health, there is a lot that we can do so that people make better choices for ourselves, right? And the insights from behavioral science can help us make policies cost effective and more easy to understand, and can in a sense increase the uptake of some of these schemes. Next slide, please. So what I will be doing is today that I will be showing how some of the lessons that we have learned from the social networks theory, when we apply them to design programs to improve full immunization coverage, how can that prove to be very cost effective along with some of the other interventions. Next slide, please. So in terms of the problem, I think worldwide an estimated 19.7 million children still die from diseases that can be easily prevented due to vaccines. And we all know that vaccines are one of the most cost-effective ways to reduce disease and disability among children. And governments around the world, especially in low and middle income countries, have made huge investments. They have made these basic vaccines absolutely free of cost. And they have invested a lot in improving the supply side of these vaccines. So for example, even in India, huge investments have been made to undertake immunization drives and really do a lot of campaigns. Despite that, in 2016, the full immunization rate in India was only 62%. And we have seen improvements, but there is still scope to do a lot more. Next slide, please. And one of the very interesting things that we see, and this is data from the state of Haryana, is that we find initially there is increased uptake, but over time this sort of goes down, it tapers off, which really highlights to us the fact that there is internal motivation, but for some reason the parental demand doesn't keep up. And we all know that there are multiple doses that we need before the child turns 12 months. Next slide, please. So the problem on the parental side, it could be many things. And what we find that it could also be the opportunity cost of the time. It could be that they don't see the salience or the impact of these vaccines because, it has a more long-term impact. So one of the things that we tried to do in the state of Haryana, next slide, please, was to really design different interventions that can nudge demand or that can nudge and improve parental demand. And each of these different interventions that I will just describe in a minute have been studied in the past, but no one study has looked at them together in combination and have tried to assess the scalability and the cost effectiveness of a combination of these interventions. So the first intervention that JPAL researchers did in partnership with the government of Haryana was to provide incentives to caregivers, and the incentives were in the form of mobile recharge that would directly go into their mobile phones. And here again, there was a variation that some of these were flat. So with each dose, they would get some recharge. And and in other cases, the recharge amount would keep increasing with each dose that the child successfully received. They also send them targeted reminders. So a phone call and a message would go to these parents, reminding them that they need to take the child to get the child vaccinated. And finally, one of the most innovative interventions was that they use social networks to identify individuals within a village who were really good at spreading information, right? And to these, they were enrolled as immunization ambassadors who were given a phone call once a month, and a message was sent to them to talk to other people in the village about the importance of vaccination and taking the child for vaccines. Next slide, please. And this evaluation was done at scale in partnership with the government of Haryana, who essentially implemented the intervention. And our researchers used experimental results and machine learning techniques to really identify the effectiveness and the cost effectiveness of different packages or different combination of interventions. It was a really huge study. So it covered 140 primary health centers, and which kind of led to 295,000 children being immunized during the course of the study. Next slide, please. And this was also digital intervention. So with the help of MIT, we developed a very simple e-health application, which all the nurses were able to adopt across the state. And by using this application, they were able to register the parents, take their phone numbers, and also create a unique ID for the child, and then use this data infrastructure to also implement the intervention, that is to send incentives to their mobile phones and track the different outcomes. Next slide, please. So the results, what we found were that local ambassadors, which were identified by the community, and the text messaging was the most cost effective. So it increased the vaccination by 26%. And it was actually less expensive than the status quo that was already existing in the state. And the text messages alone had no impact. The second combination that we found to be most effective was a combination of all three. But here again, what we found was that they increased the vaccination by 37%, but this was costly than the status quo. But what was really important is that in areas which really had very low immunization levels, this really helped increase them a lot more. So it was cost effective in those villages where the immunization rates were really low. Next slide, please. So I would just end my presentation by saying that what we have learned that at-scale evaluations are really important, and social networks can be a really powerful way, especially even for COVID vaccine, as we know, which may have 2 doses. This could be something that the government can easily deploy to make sure that people complete their vaccination. And next slide, please. And I would like to just end by saying that there is huge potential for applying insights from behavioral economics to social policy, and also integrating them with policymakers directly and undertaking at-scale evaluations. Thank you so much. I would end here now.
Thank you so much, Shagun. Up next, Dr. Aparajita Gogoi from the Center for Catalyzing Change will share more about improving school health ecosystems through multi-stakeholder participation and engagement. Aparajita, please.
Thank you. Good evening, good morning, and thank you everyone for joining, and thank you AVPN for this opportunity. In my 7 minutes today, I will try and talk about how we can leverage existing ecosystems like schools to positively impact the lives of young people. Next slide, please. So a little bit about our organization. We've been working in India for the last 30 years. Our vision is a future in India where women and girls are fully empowered and enabled to realize their rights, opportunities, and achieve gender equality. And when it comes to programming for young people, we have been focusing on working around testing and implementing programs at scale. We just heard Shagun talk about evaluation at scale, and I will be talking about kind of efforts to implement at scale via sectoral partnerships. And this is what we've been trying to do for the last decade and a half. Next slide, please. I also wanted to very quickly kind of touch upon what are the kind of challenges that we are addressing at an individual level through our programs. As many of you may know, India has a large kind of population subset of adolescents, 253 million. This comprises of about 21.4% of our country's population. And from among these 253 million, 120 million are girls from 10 to 19. And the existence of this particular group of girls is quite invisible. And in our programming, we try and cater to the needs of these girls. But coming back to this cohort, we all know that this cohort will be a determining factor in the future of India. And that is why we need to invest in programs that really support these young people to reach their full potential and thereby contribute to the progress of the country, and so that the country can actually reap demographic dividends. Now, as you can see from the slide, the data about the state of young people are not really very encouraging, especially with the onset of COVID. There is at least some kind of focus on mental health issues, but we do have data like a person committing suicide every hour in India. When it comes to health, you can see that over 50% girls are anemic. And when these girls get married young and they bear children early, an intergenerational cycle of anemia is perpetuated. We also know that the habits that we pick up when we are young, it contributes to about 30% of the non-communicable diseases that we suffer in adult life. And therefore, it is also important to work on these issues with young people. About prevention of violence, well, we see data and read reports of such violence almost on an everyday basis. So I'm not going to dwell really on it. Now, coming to early marriage, I have to say that we have made massive advancements in reducing the number and the percentage of child marriage in the last 2 decades. But the data tells us that even today, over a quarter of our girls are getting married before 18. And when they get married before 18, they're getting into the vicious cycle of early marriage, leading to early and multiple pregnancy and impacting the overall health and well-being. So this was the state of young people pre-COVID. And then, of course, COVID happened, the lockdown happened, schools closed, young people lost the spaces to interact with their peers, families lost livelihood. And all of these are really affecting young people's mental and physical health. And if we fear that if we do not act now, it will just increase the challenges that young people face. Next slide, please. So, I spoke about the data, but I also want to kind of, bring your attention to some of the programming challenges, if I may say so, that we face. So like I said, India has 253 million adolescents, but if we look at sectors other than government, we have very few at-scale programs and we have very few organizations who can really deliver at scale. And this is a challenge because if we, yes, little small drops makes an ocean, but we really have to kind of work at scale in order to reach our young people. A second challenge is that because India is so diverse and there are multiple pilots, multiple programs, but if you do a kind of an assessment, you will see that interventions that have been shown globally as ineffective also continue to be implemented. And the third challenge that we face is that the way the non-governmental programs are funded are for short timeline funding. Funding can be available to organizations like us for 2 hours. And what happens is because of this 2 years, what happens is that when funding comes to you in short tranches, then interventions delivered end up being either of inadequate dose, they could be of low intensity, short duration, And what happens is that then we have limited or transient impact. So what I'm pitching for here is that there should be investment in long-term programs, in long-term engagement, in really investing in capacity building and in multi-stakeholder partnerships. Next slide, please. I'm going to now take a few minutes to talk about how at a Center for Catalyzing Change, how at C3 we are trying to kind of design solutions that can be implemented at scale, adopting a system change approach for implementation. I think most of you would know that India has some very good, very large government programs for young people. And these large programs gives an opportunity for non-state entity like us to deliver at scale when we can work and collaborate with the government. So how we initiate at scale work is that we study and identify leverage points. It could be policies around young people, it could be programs, it could be schemes that particular states are kind of implementing, or it could be a program at the national level. But once you identify a scheme which allows you to kind of collaborate with the government, then you go ahead and you build a case for change. You present evidence that points to the efficacy of the model that we are proposing. Then we go and kind of demonstrate the proof of concept, and then we replicate at scale in collaboration, and kind of not just reduce it to, like, let's say one district or one state, but really figure out what kind of evidence, what kind of advocacy, what kind of program model is required for mainstream adoption. One example I would like to give here is the Government of India School Health and Wellness Program, which is being implemented under Ayushman Bharat. And if you look at this particular program, it's a nationwide program, and it is designed to foster resilience and health consciousness among young people. And this is an example of a scale that C3 is leveraging to reach young people at scale. So along with multiple partners in multiple states, we are partnering to support better implementation of the program. C3 itself is partnering in Bihar, Jharkhand, and Chhattisgarh. And this particular program is an example of a collaboration where different people bring in their different sets of skills and really try and kind of ensure that a program that exists is implemented in the best possible way so that impacts are visible. And I'd also like to kind of talk about that, even during COVID and school closure, this was comparatively a new program. But despite all of these challenges, the program has shifted to a kind of a blended mode where digital mode played a big role, and the Ministries of Health and Ministry of Education really worked together in order to make a difference in the life of young people. Next slide, please. Thank you for playing this video. So we measure impact through external evaluations, third-party evaluations. But for today, for all of you, we thought that we will share an impact story in 30 seconds, which also points to the impact at individual levels, although you may be implementing large programs. Thank you. I just wanted to go to the last slide. So what are the takeaways that I want to, the previous slide, please. Yeah, so what are the takeaways that I want to leave you with? Number one is a call for investment in kind of, opportunities, programs that build resilience in young people. I think COVID has made it apparent to us that resilience building efforts, which build the confidence and leadership in young people, is really, really required to address multiple deprivations. And once young people are skilled and equipped, they can deal with crises like COVID-19 in a better way. So the first takeaway is that let's invest in resilience building for young people. My second kind of message that I want to leave behind is that we definitely need more collaboration when we talk about working with young people. I've already given the numbers. So I think everybody should collaborate and support large-scale, multi-pronged partnerships with NGOs, with CSOs, with state government, with private players, with district administration, so that all of us can reach out to young people, their parents, community structures, and frontline workers. And my third kind of message is that this is not going to happen automatically. So we have to invest in building an ecosystem for scale. And this ecosystem for scale, the foundation has to be the involvement of multiple actors, multiple stakeholders, and we need to leverage each other's strengths. So lastly, I would want to kind of conclude here by saying that when we talk of looking at issues, solving issues that face young people, it's really important that we adopt a holistic lens. We recognize that no one party or one intervention can address all the core building blocks of young people's health and well-being, and that's why collaboration is key. Thank you so much.
Thank you so much, Aparajita. Up next, Kalpana Bizabatuni from Sight and Life will share more about investing in food system innovation hubs to address malnutrition. Kalpana, please.
Thank you. Thank you, AVPN, for the opportunity. Good evening, everyone. Sight and Life's mission is to advance innovations that could end all forms of malnutrition. And nourishing 10 billion people on Earth safely and sustainably means we have to reconceive food systems. So today I will share this new initiative of ours called the Food Systems Innovation Hubs. Next slide, please. So we're all aware that our planet is getting more and more burdened by rising temperatures, diminishing resources, and exploding population growth. And if we add malfunctioning food systems to this mix, it gets even worse. For example, today, 80% of our agricultural land is affected by soil erosion, and a third of the food we produce is wasted. And because of this inefficient food systems, there's a 20% decline in the global availability of the essential nutrients that we need. And as a result, our ability to nourish our 10 billion people has been diminished, and we see unprecedented levels of malnutrition than ever before. So malnutrition has two phases. On one side, we have nearly 150 million children under the age of 5 who are stunted. And on the other side, we have more than 2 billion people who are overweight or obese. So what do we do, and what is it that we can do? Next slide, please. So to end all forms of malnutrition, we need to enable environment-friendly food systems that are local, resilient, and also responsive despite the shocks that we currently see, like the pandemic. And we believe that the power of this transformation from failing food systems to a robust mechanism lies in the innovation hubs. So we seek to establish a food systems innovation hub in India, which will be able to mold itself to the needs of our country, our communities, by engaging directly with people, our culture, entrepreneurial talent, and India's unique climate. But to do so, we must focus on 3 actions: inspire, invest, and innovate. When we say inspire, what we plan to do is we want to encourage existing exceptional food technology companies with market prowess to expand into India with the goal of aligning with the range of investors, specifically impact investors, develop and test new products. And we hope to inspire innovation, invest, but also consumer interest. And when we say invest, we are talking about facilitating investment in local companies that have the potential to scale. And when we talk about innovate, we want to stimulate innovation throughout the value chain of nutritious foods, but tailored to Indian markets, and draw additional investment that is especially impactful to small and medium enterprises and social enterprises that dominate food production today. Next slide, please. So what kind of transformative change can we expect through innovation? We can really have tasty, nutritious foods which are affordable and accessible in the last mile, all the way to improving livelihoods, especially for smallholder farmers. Next slide, please. And in terms of the hub itself, what is it that the Innovation Hub can offer? The Innovation Hub can offer a range of labs, from processing centers, nutrition science, to consumer insights and more, but also access to testing new products, marketing activities, but also connecting with relevant partners, say, for example, for a social enterprise to scale an innovative product. Next slide, please. Now, when we say innovations, we're talking about different types of innovations, from products, technologies, business models, right, but even social marketing initiatives. And innovations there themselves are eclectic in nature. And the role of the hub is to make them cohesive and widely available. And at Saturn Live, we have already witnessed the positive impact of innovations globally. What you see on this slide is one such example, which is called micronutrient powders. It's generally a mix of vitamins and minerals that are added as a top-up to any food a baby, infant, or even pregnant mother eats. And now this particular product has been endorsed by WHO. Next slide, please. And a relevant example on product innovation for India is what you see on this slide. So we are working with the Ministry of Science and Technology and the Bill and Melinda Gates Foundation to test 3 innovative, instant, nutritious egg-based snack concepts as a healthy alternative to the rapidly growing junk food market. And we expect the innovation hubs to bring out more such healthier alternatives to junk food. Next slide, please. So it's not just about tangible products and technologies. It's also about capacity building, especially in nurturing the young entrepreneurs whom you see in India, many of them in India. And the hub can act as a platform for those who do not have access to technical advice or even seed funding for an innovative concept. So at Saturn Life, we have tried and tested concepts like the elevator pitch contest, where champions of social change are being empowered. For example, in India, the Karuna Innovations, it's a Mumbai-based startup, was one of the finalists from the contest. They've developed a very innovative digital technology for high-risk pregnancies and have now touched the lives of more than 100,000 mothers, especially from vulnerable communities. Next slide, please. However, what's the use of an innovation if it's not adopted at scale? And that's where partnerships play a role. And this is where we hope the hub will also be able to connect the right partners to different partners. And the reach of our partners like UNICEF and World Food Program is colossal. Now, there's so many examples I'd like to share, from business models to social marketing, but I'm running out of time, and these are available on our website. I would like to skip to the last slide and say, why did we choose a hub for India? It's a developing economy, and the hubs are a bold new initiative. And India needs drastic and cutting-edge game-changing solutions to tackle the massive double burden of malnutrition that we see. So the hubs would be perfect fit to address this range of malnutrition. And please reach out to me. We would love to partner with anybody who's interested in the food systems innovation hubs. Thank you.
Thank you so much, Kalpana. Up next, Dr. Ashwin Naik from Xunital will share more about collaborating for accelerating health innovations at the last mile. Ashwin, over to you.
Thank you. Thanks very much. So next slide, please. We've heard a lot of great presentations about grassroots innovation and how different partners are coming together. I want to take a little bit of a different angle to it and zoom out a bit and talk about health in general. So if you look at healthcare, COVID really didn't start the fire, if I can use Billy Joel's words. I think it was always burning. It just exaggerated what was happening in the health sector. And the big challenge with health sector is that we don't have an innovation problem, we have a scalability problem. There's hundreds of new innovations come about and don't reach the scale that they should reach. And we believe, like other speakers have said, the problems are: one, there is a side approach. The second, there's too many pilots. And third, there is lack of credible test beds. So our mission at Zentio is to build a playbook for scaling medtech innovations in partnership with the private sector and of course the government. So that's what I'm going to talk about today. Just a little bit of background on Zentio. Zentio is a Norway-based organization focused on building coalitions primarily with private sector partners, but also involving government and social sector and startups. So we started a few years ago in India, and the The initial focus was for 3 years, but now we are going up to 2030. It was launched by the then President of India, and we work with multiple partners, partners like Unilever, Shell, and others, including Tata Trust, and governments across the country. If I speak about what we are doing specifically in the health sector, we realize that the next slide, please. The next one. Yeah. So what we have done is, like I mentioned, to address these three issues of a siloed approach, unscalable innovations, and lots of pilots, we said, why don't we build a playbook that brings, create a platform that brings all these stakeholders together. And over the last 3 years, we've been able to bring a strong community of about 150 business and government leaders from over 50 organizations together. And the idea is we use this platform to accelerate innovations across multiple geographies. Next slide, please. So what are the current challenges that we are seeing? I think there is, somebody mentioned CareNX as an example. Now, CareNX has reached 100,000 people, but it could literally reach 10 million people in India. And the challenge they face is they don't have access to credible testing, test sites, and then also sponsorship from the right governments. They don't have the clinical partners that they can work with. And then finally, they don't have the industry partners who can help them in scaling up, both in terms of design and distribution. And they have to deal with complex regulatory channels and public health procurement process. And this problem is not just in India. I think it's across the world, except the developed economies. So we believe that there's an opportunity to create this platform. Next slide, please. So this partnership together formally launched last in the month of February with the state of Telangana as our key partner. And we brought together a whole bunch of hospitals, industry partners, startups together, and have now created access to these innovators to scale up their projects with this platform. Next slide, please. So if you talk about how we do it, we believe that the first step is to bring the key stakeholders together. And for many years, healthcare has started with a solution in mind and then trying to look for the problem. And we have seen that that's not scaling. So we believe that bringing all the stakeholders together, identifying what are the key challenges, and then building on it. So we start with bringing a problem statement in association with our state government partners, identify the right private sector and the startup or innovative partners, provide them access to a great cluster of test beds, and then provide them access to industrial settings, and then work with them to access the market through the public sector. One example for this is currently we are working with an organization called MemoCare, which again is like CareNX, and we have facilitated a conversation with a large hospital group, and hopefully through that process they will come into a much larger market. Next slide, please. A platform like this can be used for multiple needs as well. One example is the state of Maharashtra, the city of Mumbai during COVID was looking for some solutions to rapidly scale their screening. So because we had the platform, we were able to quickly pull together a bunch of partners who were then able to screen door to door in a very dense population. And this project now has taken off, and there are discussions to bring the same methodology of identifying partners and scaling screening to close to 10 million students across multiple geographies as part of the school health program. So we are really focusing on the platform, not so much on the technology or the implementation piece. Next slide, please. Like I mentioned, we have been successful in getting various stakeholders, not only people from the health sector, but also people who could facilitate in communicating and also design and behavior change communication as well. So where are we now? We have launched last year. Our mission is to get 25 companies, 25 small companies to reach scale in the next 5 years. We have an estimated budget of about $1 million, out of which about 1/3 we have been able to mobilize, and we are looking for additional institutional partners to come share with us your scaling challenges in the healthcare sector, or bring innovations that you strongly believe in but have not scaled. Would like to work with you and figure out how to work with our platform. And finally, if you're looking to invest in something which could be a playbook that can be used in multiple geographies, please feel free to reach out to us. Thank you very much.
Thank you so much, Ashwin. And with that, I'd like to hand it to Rajesh Singh from LEHS Wish, who will share more about transforming healthcare through technology and innovation. So Rajesh, please.
Thank you for inviting us and giving us the opportunity to share some of the learnings that and the work that we have done during the COVID period. You know, most of the presenters have really touched the key aspects of how their models have evolved, and so do us, like our model also. Next slide. Wish, being at the forefront of transforming the primary healthcare, we were in the right place at the right time with the right kind of approach to really tackle, deal with, and address the issue from the last mile perspective, vis-a-vis COVID there. Some of the information about the institution is that we are working currently in 5 states. We play both kind of roles there. We are an innovator and an implementing agency also, but those are basically from developing the proof of concept, getting it evaluated internally or with the external agencies there, taking it to the various stakeholders, and primarily because primary health and the health is a state subject, we really reach out to the various states, and we have the agreement with all the 5 states, especially Rajasthan, MP, Delhi, and Assam, where we play the techno-managerial or knowledge management partner role there. And during the COVID period also, we played that critical role. Most of us are well aware of the challenges. We have read it, we have experienced it, we have really spoken, discussed these aspects of how the whole COVID really changed the health paradigm, and especially the primary care paradigm there. The shortage of healthcare providers, it's not it's obvious, in fact, most of the places you will cite, there is a find that almost 35 to 40% human care healthcare providers shortages are always there, and COVID really added to it. Places like Delhi, we have just remain with that slide, please. Thank you. Places like Delhi, where just take it back to the previous slide, last slide. Thank you. Places like Delhi, where there are around 500 mohalla clinics, 9 deaths among the doctor and healthcare providers, it's really shaken the confidence of healthcare providers there. So they were at the risk there. And there were chances that whole mohalla clinic program or primary care program will really suffer. Luckily, I think we really found technology as an alternative for a stopgap arrangement or certain period to really continue to provide the services which we could have really provided that. We also found, because most of the healthcare providers, they were really worried about and completely ignorant about the COVID, the disease, and the treatment part, and also about the new guidelines that were emerging every week, and especially between the March to July, we all remember it, how on a weekly and fortnightly basis, the guidelines were changing, and so does the guidelines was impacting the primary healthcare providers also there. So the one way which we really took out is that virtual training programs where the person gets an hands-on experience using the virtual technology there to really continue building the knowledge, enhancing the knowledge, and continuously providing the services there. And the knowledge was both on the soft and the hard skill part there. Our solution is totally digital and technology driven there. And if you really see this, it's completely based on, the model of 3P and the C part, which is primordial, preventive, promotive, and the curative model there. So this whole life cycle approach of primary care that we have adopted, it really helped us start building the confidence, like through within the community setup, building the confidence of the healthcare providers. So both the supply side and the demand side, we started working simultaneously also. And that really helped us in continue to provide the services, at the same time build the confidence of the last mile in accessing the services, mostly to the digital health platform there. Next slide, please. As I was talking that, it was a periodical, every week, it was a crisp 30 minutes virtual training programs that we were doing it. And we did it with, in the first 6 months, around 27,000 healthcare workers who were in directly touch, either through the direct intervention or the technical support role that we play in the various states there. Not only that, but of course, continue providing the various safety kits for them, so that they continue to provide services there. We really, being an agency which has really piloted, tested, and scaled over 35 point of care devices from the primary care lens. We also use many of those devices which were non-touch kind of devices, point of care device, for continuity of the primary care services there. Of course, the example that I was putting, we were anyway working on a virtual capacity building, models and modules for learning. And these are basically self-learning models and modules, and facilitated learning and modules there. One can really do a self-assessment as well as external assessment to really see how much he or she has really acquired the knowledge, correct or accurate about that. As we were working on this, we realized that we also need to really develop within the primary care perspective, a community containment strategy. And that's something that we really developed with the first time, keeping the primary health center as the conduit there. Right from the beginning, we have been working on telehealth services. And as the first speaker Shama was talking about that, how COVID has really given impetus and brought the whole digital health 5 years or 10 years ahead of this. We started piloting this program called Digital Health and Wellness Center project way back in 2018, and we presented at the National Forum, got widely appreciated nationally and internationally. But we were really finding difficult to convince the states where we are a techno-managerial partner to really move into that domain there. However, COVID gave us that impetus. Next slide, please. Can we move to the next slide? These are, and the three models that really evolved is that each district of Madhya Pradesh, within the district hospital, we set up this command center where, and the telemedicine, that was from April to July, as everyone was clueless about how to really address issues. Second was this whole demonstration model of tech-enabled model within the labor room for continuously providing the labor room services to the pregnant and pregnant mothers there. And the third one is that setting up in a private domain, the isolation ward when everyone was finding it challenge. And that got really scaled. Those are the three models that we really feel that also over a period government has really scaled. The numbers are in front of all of you, 8 million reach. Influenza symptoms are roughly around 765. People who were admitted through our services and are roughly around 2.3 lakh. Household that our team directly surveyed is around 5.4 million. And the healthcare providers that we talked earlier is around 27,000. So that really talked about, if anyone would like to really know more, you will be we'll be happy to really show the learning that we have over a period of time. Thank you.
Thank you so much, Rajesh. And with that, I will hand it over to Pradeepa Pandey from Child Fund India, who will share about their work in investing in adolescent reproductive and sexual health. So Pradeepa, please.
Good evening. This topic is different from the topic which other speakers has presented. This speaks about adolescent reproductive and sexual health, which is a major concern and problem in our country because it's a conservative country, and talking about these things requires a skill because it's not easily, people will not accept, the parents of the adolescent will not going to accept it the way it should be because it's still a taboo. Next slide. So just an overview of the Child Fund. We work in India since 1951, and we are working in 15 states. We have around 4 million children, youth, and families which are in hard to reach areas like tribal areas, vulnerable groups, socially excluded group. We work with them and we focus with them. So for us, the children are from birth to 15 years, 24 years of age, and we actually work in life stage approaches. Next. These are some of the programs we do. We do health programs, which is, and we have a models, projects like Machan, mother and child health. And then we have education models, we call it pencil, and then livelihood and empowerment model also. So for health, we mainly cater to 4 to 5 year children, and in adolescent, when they go in the adolescent health programs we have. For education, we start with preschool education and in schools, and then the higher education. And for livelihood, work with children who are above 15 till 24 years of age. And then we work in child protection because Child Fund major focus is protecting children from all kind of neglect, abuse, and all that. And also we work on disaster risk management, and we reach 2.1 million children in a year. Next. So I will talk about Garima. Garima, as the name says, it's dignity for girls and also for boys. So with dignity, we say we have a knowledge on OSH. It's about empowering girls to speak about OSH and also the boys to speak about adolescent reproductive and sexual health issues. Next slide. So it's just an overview of what is the scenario of adolescent health, especially the sexual health in our country. So if you see 31% youths are affected with HIV. The different studies are happening, and we find that 26% girls and 20% boys are already, they are married by the age of 18. Out of it, 7.9% already have a child. Only 7% girls and boys, they say that they used modern contraceptive method. And if we look at menstruation hygiene management, only 36% adolescent girls in our country, they use sanitary napkins or hygienic clothes during menstruation. Still 60% adolescent girls are anemic in our country, and only 38% adolescents have SRH related knowledge. And out of that, only 19%, which is very, very less, not only knows, they adopt safe sexual and reproductive health practices. So Child Fund does is we do studies also wherever we are doing this Garima project, and through it only we have come to know. There are different studies we conducted, and also through studies by UNICEF, it is saying that 40% girls, they drop out from schools because there are no toilets, wash facilities are not there while menstruating. So next slide. So what is the solution? The solution is to make these girls and boys, providing them with accurate knowledge, authentic knowledge, and age-appropriate knowledge on OSH. So even in our country, sex education is a taboo, and many of the state has not accepted it, and it's not the part of curriculum in around 9 to 10 states in our country. So what we wanted to do through Garima, we want that all adolescents who are in the age group of 10 to 19 should have improved reproductive and sexual health behavior. And also, like they should have comprehensive, correct, and appropriate knowledge. And not only knowledge, they should be adopting all these safe and healthy sexual practices, because where we walk in the rural areas, or even in urban areas, there are sexual reproductive health practices which are harmful for girls and boys. Also, so it's not only behavior and knowledge, they also want access to the services, that adolescent health services which are provided to them should be adolescent friendly. But if you look at our primary health centers, you will find these are not adolescent friendly. Like for girl, there is no adolescent health counselor, or for male, there are not male doctors who can provide a comprehensive knowledge about them and also provide services to them. So what we do, so major interventions which we do for it is adolescent nutrition. So we are providing nutrition counseling and IFAs so that their nutritional status is improved. Uh, uh, One of the best practices of this Garima model is the peer educators, because adolescents, they learn more from their peers. They are close to their peers, and peers are the source of authentic information. We use them for authentic information, but most of the time when they are not trained, the peers are not trained, they give the wrong information to the adolescent girls and boys. So we encash them and we train peer educators. We form adolescent groups and train them on adolescent reproductive and sexual health. In schools, we train teachers and even the student, and strengthen the school management committee on sexual and reproductive health. Uh, the major component of it is reproductive and sexual health rights, which is universally acknowledged. So the adolescent groups, they also act as an advocacy group for adolescent reproductive and sexual health rights. Menstrual hygiene management, which is a major problem in some of the states like Rajasthan, we are working, and in Jharkhand, so where we have picked this component to work on. So all these things are done through life skill education. So we provide the life skill education, and the part of life is education, the component is ORSH. So we put it. Also, I said that because parents play a very important role in ORSH, and most of the parents in our country, they don't have the skill to impart knowledge to their adolescent and boys and girls on SRS. They don't know how to start the discussion. So for that, we have a package and program. We say family matters program for parents. So we're doing sessions with parents, telling them how to start speaking about sexual reproductive health, and building a cohesive environment for these adolescent girls and boys. And then the gender-based violence, because sexual uh, uh, it's providing knowledge about, there are so many gender-based violence also which is linked to ORSH. So these girls and boys are trained on it. So we are working in around 26 districts in 15 states across India, and we have reached out to 3 lakh adolescents who are from vulnerable groups, who are from disadvantaged group. And Garima intervention, if we see, these are not the new, very new intervention. In fact, these are the best practices, which is the part of National Adolescent Health Program, which is implemented by the Government of India. But the Government of India they are focusing on provision of services like counselor, adolescent health day. But if you look at the community part, it's missing. So we did that. We have demonstrated that we have more than 500 peer educators which are trained on ORSH related issues. And if you look at the findings of online findings, it says that earlier it was 32%, but now 62% adolescent girls, they reported that they are following menstruation hygiene and they are happy about it. Uh, with the Government of India, we have advocated and around 148 adolescent-friendly health clinics are established at primary health centers. We have a big program on it, the government of India, Rashtriya Kishore Swasthya Karikram, but as you know, we have good policies, good programs, but if we look at the implementation part, there are lots of gaps. So we have done that, we have established that. And in the community also, we have adolescent health, we have established adolescent health clinics. So if you look at the parent through Family Matters programs, more than 3,200 parents have been trained. It's not only training, it's the session, 4 to 5 hour sessions for 12 days, in which parents are told and also practiced that how they can communicate about SRH to their children, and it will help in building positive environment and telling them that talking about sexual and reproductive health doesn't promote risky behavior. Otherwise, it actually reduces the risk of sexual harmful practices and risky behavior if we tell the girls and boys about sexual and reproductive health. Next slide. So these are the impact. Around 700 adolescents have been trained on adolescent health rights. We have engaged families and all the other grassroots level workers. As we said, we have done Family Matters program, talking to the fathers, especially with the mothers, on ORS related issues, because anemia is a big issue in our country. So we have projects, we call it Rani, under ORS only, where girls are counseled, they are provided with IFA, and they are referred to the first referral unit so that they can get all services related to anemia prevention. Yeah, the findings says, yeah. And then next slide. If you look at in the COVID, when the COVID came, ORS-related activities were also impacted. And when it was announced, the lockdown was announced, the major issue was most of the girls, they do not have access to sanitary napkins, because it was in the market, it was not clear like whether the sanitary napkins could be the part of essential services or not. So there was a huge supply issues. At that time, we provided girls, because these peer educators are the depot holders, so they already have that. We in the Senate, so they worked on those in that. So in the COVID-19, these peer educators, when they were doing home visit, they also addressed the shortage issues of IFA, napkins, and other things. These girls who were trained, they were trained on when COVID came, lots of misconceptions and came with them, so wrong information. So the girls, they provided information, and they tried to reduce stigma and taboos and other things which were related to the COVID also. COVID peer educators, because we already have a IC on ORS, so we incorporated the messages of COVID on this. These are some of the communication materials which we have used for adolescent reproductive and sexual health. Small booklets, IC, and all that.
Deepak, I don't mean to interrupt. Can I ask you to wrap it up so that we can hand the floor to our last speaker of the night?
Okay,
Sorry. Thank you so much.
Thank you.
Perfect. Okay, thank you. So with that, I would like to hand it over to our last speaker of the night. So last but not least, we have Professor Vivekant Jha from the George Institute for Global Health. He will share about their outcomes using technology for better healthcare in primary healthcare settings. So Vivekant, over to you, please. I think you are on mute, so if I can just ask you to unmute yourself.
Yeah. Sorry, can you hear me now?
That's perfect. Thank you so much.
Great. So I'm pleased to have the opportunity to present our work around the use of technology to improve healthcare outcomes in low resource settings. It's fair to say that not only for India, but for the world, the single greatest health challenge today is how to provide care to 7 billion people, out of whom 5 billion have no reliable access to essential care, and 2.5 billion will develop a severe disease before the age of 60. You know, this slide, can I go to the previous slide, please? This slide shows the top 10 conditions most likely to cause premature death or disability around the world. We can see that non-communicable diseases are in the top 5 and are growing almost on a daily basis. Non-communicable diseases produce few symptoms, they remain undiagnosed for long periods of time, require lifelong care, and lead to catastrophic healthcare expenditure. Here is an example from one of our programs in Andhra Pradesh. In a survey of 2,400 adults representing more than 95,000 people of rural Uddanam region, we found that out of almost every 100 people, 42 had high blood pressure, 13 had diabetes, and 21 had kidney disease. These figures are more than double of previous known estimates for these conditions. What is even more striking was the fact that out of every 100 persons with diabetes, 44 did not know that they had the disease. The same was true for hypertension and kidney disease as well. It is well known that most people with severe conditions such as coronary heart disease and cerebrovascular disease in low-income countries receive no treatment whatsoever. Most people at high risk of developing cardiovascular disease actually live in resource-poor regions of the world. In high-income countries, the number of such people is estimated at almost 80 million, whereas in the resource-poor regions, it is more than 3 times, almost 250 million. Now let's contrast this with available resources. High-income countries spend almost $100 billion for 80 million people, whereas low-income countries, about 1/5 of that for 3 times more people. Similarly, you can see the contrast in terms of the number of medical workforce. North America and Western Europe have between 27 and 32 doctors per 10,000 people, whereas Sub-Saharan Africa has just 2 and Southeast Asia has just 3 doctors for the same number of people. Thus, it's fair to say that we have vast unmet need. In addition to inadequate workforce and resources, there is great variation in the quality of care, and the cost of care is prohibitive. As a result, what happens is that every decade, tens of millions of people die prematurely and unnecessarily from preventable causes. So, what is the solution? We need radical change. Clearly, incremental change is not enough. Can I request you to stop clicking, please? We need innovations to ensure essential healthcare access to the bottom 3 billion who live in less than $2.50 a day. This care needs to change from high margin, low volume to low margin, high volume care. So where do we start? Of the various reforms we need, the most critical is the use of technologies. In the next couple of minutes, I will tell you about a program of work that we have implemented in several countries in Southeast Asia. The innovative healthcare model has a digital health platform as its backbone. It relies on community healthcare workers who work under remote supervision using wireless point of care devices and diagnostics, and they also use evidence-based algorithms which allows continuous quality control. This program is called Smart Health. It is administered by frontline healthcare workers at people's homes. Data gets uploaded into a cloud-based platform and provides prompts to healthcare workers, doctors, as well as to patients through a cloud-based continuous decision support. Now, going from registration to history taking to risk factor determination to treatment advice, just 4 steps involved, and the patient is his on her own way. Smart Health has a number of enabling components: training, remuneration incentives, voice response systems, inventory management, communication tools, multimedia resources, and recall and reminder systems. All of this, of course, works within the public sector healthcare system. I'll now present our result of 2 such programs in Andhra Pradesh in India and East Java in Indonesia, where Smart Health was implemented for 2, I will show you just 2 pieces of result. Using digital health technologies, healthcare workers were more efficient in identifying high-risk individuals compared to primary care physicians who used their own skills and did not have access to any algorithm. And here is the next bit of data. When they implemented a program of treatment, the proportion of individuals receiving blood pressure lowering treatment and achieving target blood pressures went up from about 25% at baseline to 64 to 65% in 6 months period of time. All this happens in collaboration with stakeholders, to state government and central government, academic institutions, civil society organizations. With each of them, we ensure that their priorities are addressed, keeping the patients and healthcare systems in the center of this entire enterprise. The Smart Health platform has now been used across multiple regions in India, which are shown on this particular slide. And all this funding has been done through peer-reviewed funding sources. We have already invested a huge amount of money. I'm not going to go into the details of these individual projects, but would invite you to have a look at our website, www.georgeinstitute.org.in, to see the details of these programs. We welcome partnerships. We have used these technologies in other conditions, such as emergency care and rehabilitation, with the eventual goal of reducing premature death and disability. Our program emphasizes cross-disciplinary scientific partnership, engagement with social impact investment sector, with focus on implementation, scale up, sustainability, and affordability. I invite you to join us on this journey, and thank you for your attention.
Thank you so much, Vivek. With that, we have come to the end of the Grandstand on Healthcare. This session is made possible with the kind support of our festival partners: Bill and Melinda Gates Foundation, Sesame Workshop India, the Rockefeller Foundation, COVID Action Collab, V&V Advisory Services LLP, the British Asian Trust, WPP India CSR Foundation, Catalyst Management Services PTE Ltd, and Satwa. We encourage you to continue chatting with your speakers and fellow delegates in this session, so please do make full use of the messaging and meeting function on our festival platform. Do share your highlights of this session on social media, and remember to tag us using the hashtag AVPN South Asia 2021 and hashtag social impact. The festival will continue next week on Tuesday, February 9th, when we will shift our thematic focus to livelihoods. So do join us for the opening remarks and a fireside chat on unlocking capital in Tier 2 and Tier 3 cities at 4 p.m. IST next Tuesday. Thank you, and please enjoy the rest of the festival.